Hi, in this screencast we're going to review mechanisms of cardiovascular pharmacology. So here's just an overview of the structure of this talk and the next talk. One is just kind of trying to think about why these drugs are so hard to learn and some observations. Then mechanisms of cardiovascular drugs, and then finally kind of pulling together those mechanisms into practical clinical use and indications of how to use these drugs in cardiology. So first, why are these drugs so hard? There was a lot of feedback that many people wanted review or some sort of synthesis of cardiovascular pharmacology. And I think one thought is that cardiovascular therapeutics are multimodal. So for example, a patient with myocardial infarction and EF of 30%, you treat this patient with several modes of therapy: behavioral therapy, quit smoking, pharmacological therapy, and you can see there are a whole slew of medicines that this patient might qualify for. Procedural therapy, the patient might need a stent, the patient might need a device implanted, and if the stent fails, for example, or the patient continues to have angina, they may need bypass surgery. So there are a lot of different modes of therapy for cardiovascular disease, and what we've tried to do in this unit is put the pharmacology in the context of the indications or the overall disease process. But it's possible maybe you went too far and you need a little bit more background on the pharmacology, or at least think of them separately. So the second thought is that especially for cardiology, cardiovascular indications for drug therapy are overlapping, and the differences among the drugs, or rather the use of the drugs, can be subtle. So the same patient, that same person with an MI and an EF of 30%, could have 4 separate indications for a beta blocker. He or she might qualify for a beta blocker because they have left ventricular systolic dysfunction. Since their status post-myocardial infarction, they also qualify for a beta blocker. If the patient, let's say, had high blood pressure, a beta blocker might be a good antihypertensive for them. If the patient had an arrhythmia, for example, ventricular tachycardia, say in the CCU after the infarction, the beta blocker might be used to sort of suppress ventricular tachycardia or as an antiarrhythmic. So 4 separate indications for the same patient, all sort of in the same wheelhouse, somewhat overlapping indications. So that means that sort of the traditional pharmacology paradigm by which you likely study most of your drugs, namely think about the drug, the class, mechanisms, indications, interactions, and contraindications and side effects, could fail, particularly for very commonly used drugs like beta blockers or ACE inhibitors or aspirin or clopidogrel, because it's too hard to keep straight what the different indications are. Third reason is there are just a lot of drugs. Looking through Lilly, there's really 40 or 50 agents that you're expected to learn during this unit. And unfortunately, you kind of have to know them all because most of these are commonly used in medicine. So there's just a lot of material to go through. So how do we try to make it better? Well, so my thought here is, one is to sort of reinforce the mechanisms. These were mostly gone over during the lectures, but I think reinforcing them visually may help distinguish the drugs for you. And 2, then kind of in a summative fashion, in a separate screencast, go through the different indications by disease rather than by drug. So that is to say, instead of these are the 7 uses for a beta blocker, say what are the 7 drugs that are useful for acute myocardial infarction? What are the, let's say, 5 drugs useful for acute decompensated heart failure? And kind of figure out the drug indications that way. And I think that's kind of a logical way to do it, and it's practical because then you can access that information during your clinical years. The exception we'll make is for drugs with just a few indications or straightforward indications. We'll discuss those indications here. So here's just a list of sort of the drugs and mechanisms that we'll go through somewhat in this order, and let's start with digoxin. So digoxin, to understand how digoxin works, you have to understand the sodium-potassium ATPase. It's an energy-requiring transporter, and recall that sodium concentration is high extracellularly and low intracellularly, and potassium concentration is low extracellularly and high intracellularly. So the sodium-potassium ATPase pumps sodium against its concentration gradient, and likewise for potassium. Also recall that there's a sodium-calcium exchanger which can operate in either direction. So in this way, through the mutual use of sodium in both of these transporters or channels, potassium and calcium concentrations can be coupled. So the way digoxin works is blocking the sodium-potassium ATPase. What that does is it raises the intracellular sodium concentration because the sodium can no longer get pumped out of the cardiomyocyte. And what that prevents is extrusion of the calcium through the sodium-calcium exchanger, which leads to increased intracellular calcium, which leads to positive inotropy. The other thing digoxin does is bind to the M2 muscarinic receptor, so it's a vagomimetic, and that vagomimetic activity slows phase 4 of the action potential. So those are the mechanisms of digoxin. So next we'll kind of consider the different vasodilator drugs, and this table is a nice table adapted from Lilly. I think the key thing to understand is that we separate vasodilator drugs into venodilators, so things that increase the capacitance of the venous system, thereby decreasing preload, and nitrates really fall into that category. Arteriolar dilators, drugs that decrease the afterload by decreasing the resistance of the resistance vessels in the body, the arterioles. Drugs in this category are hydralazine, minoxidil, and calcium channel blockers. And drugs with mixed effects, which are in the center here, nitroprusside, ACE inhibitors, and ARBs, alpha-adrenergic blockers, and alpha-2 central agonists, as well as Nesiritide. So we'll go through these classes here, and what we'll start with is ACE inhibitors and ARBs, and what we'll actually do is consider the entire Renin-Angiotensin-Aldosterone system and talk about those drugs. So here's a schematic of the Renin-Angiotensin-Aldosterone system, and you can see here angiotensinogen is at the top. Renin converts it to angiotensin 1, which is then converted by angiotensin converting enzyme to angiotensin 2, which combine the angiotensin 1 receptor, leading to vasoconstriction, sympathetic activity, and sodium retention through aldosterone, which is a steroid hormone, which is stimulated by angiotensin 2. So all of these effects you can see will lead to increased blood pressure because of increased intravascular volume, increased sympathetic tone, and vasoconstriction. The other thing angiotensin converting enzyme does is act as a bradykinase. So bradykinin, when it's present, can lead to vasodilation and vascular permeability, which can lead to flushing and cough. ACE breaks down bradykinin and prevents those effects. So put here in purple are the 4 different drugs that you've learned about during this unit that act at different levels of the renin-angiotensin-aldosterone system. So at the top is a new agent, an antihypertensive aliskiren, which is a direct renin inhibitor, which then affects the entire downstream pathway. ACE inhibitors are sort of the classic or most common class of drugs in this pathway or paradigm. They block angiotensin converting enzyme, thereby preventing conversion of angiotensin 2 and preventing angiotensin 2 from stimulating the angiotensin receptor. The other effect of that is that by blocking angiotensin converting enzyme, you no longer break down bradykinin and can have increased vasodilation and vascular permeability, which can increase cough in some patients, about 5%. Similar to ACE inhibitors, but not necessarily suffering from the inhibition of the bradykinase activity of angiotensin converting enzyme are the angiotensin receptor blockers, or ARBs, which directly block the angiotensin receptor, thereby preventing angiotensin 2 from binding to it. And finally, aldactone, which is an inhibitor of the steroid hormone aldosterone, which acts at the distal tubule to lead to increased sodium, to block sodium retention. So this is sort of the classic paradigm of the renin-angiotensin-aldosterone system, and as you know from Dr. Paparello's lectures, many of these drugs are very useful in treating hypertension, and as you know from Dr. Shah's lectures, many of these drugs are also useful in treating heart failure. And the imputed mechanism for these drugs, or at least ACE inhibitors, in treating heart failure is that it leads to, by administering an ACE inhibitor, it leads to vasodilation. But several other classes of medicines that are vasodilators, for example, calcium channel blockers, don't have any benefit in heart failure. So I think it's worth sort of looking at some of the sort of non-canonical effects of ACE inhibition and the angiotensin system, because these may actually affect, these may explain its benefit in heart failure. So evidence in the last 10 years or so has shown reasonably convincingly that angiotensin has direct myocardial effects. So stimulation of angiotensin may have deleterious effects directly on the myocardium, because it turns out there's an innate angiotensin-aldosterone system within the myocardium. There's even angiotensin converting enzyme in the myocardium. So stimulation of the angiotensin receptor may have direct deleterious effects in the myocardium, and therefore blocking this system with ACE inhibitors may explain some of the beneficial effects in heart failure, because it allows the myocardium to function more normally. The other piece of emerging evidence is that angiotensin receptors in the vasculature may contribute to atherosclerosis pathogenesis, and that's why sometimes clinically you may see a patient with just coronary disease on an ACE inhibitor, irrespective of the fact that they have high blood pressure or LV dysfunction. That's just something that you might see on the wards. So that's the renin-angiotensin system. Now let's look at nitrates and nitroprusside, which are two drugs which donate nitric oxide. So recall nitric oxide physiology. Nitric oxide is generally endogenously synthesized in the endothelial layer after stimulation by vasodilators. That nitric oxide then travels to the smooth muscle. It's freely diffusible, stimulates cyclic GMP, leading to smooth muscle relaxation. So nitroglycerin, isosorbide dinitrate, and isosorbide mononitrate are all nitric oxide donors, and they're considered the nitrates. And you can see the NO groups here on the ends of these molecules. Nitroglycerin is used as an IV medication or can be sublingually administered. It has a half-life of about 5 minutes, so very short-acting. And isosorbide dinitrate is used as a TID or 3-time-a-day medicine because of a half-life of about 6 hours. And isosorbide mononitrate with a half-life of about 18 hours, so there's a once-a-day administration. And it turns out that the nitrates are mostly venodilators, although they do have some arteriolar dilation abilities. And that's what explains, for example, when they are arteriolar dilators in the coronary beds, that explains their anti-anginal activity. And where they're arteriolar dilators in the facial arteries, I guess, it can lead to flushing. So because nitrates are mostly venodilators, although they are anti-anginals through virtue of coronary bed arteriolar dilatation, predominantly they decrease preload because they're increasing the capacitance of the venous system. But higher doses can lead to decreased afterload. And so it's important, because they decrease the preload so much, you can really drop the blood pressure of someone who has low blood pressure to begin with. So you can't use this medication in patients with low blood pressure. So we use sublingual nitroglycerin and these other nitrates in patients with angina. IV nitroglycerin can be used in patients with acute decompensated heart failure to decrease their preload. Sodium nitroprusside is a pretty similar drug, except it is classified as a drug with mixed arteriolar and venous dilation. This means that it decreases preload and afterload, and because of that, it's very useful in hypertensive emergency. And it's also used in acute decompensated heart failure because dropping preload and afterload in that condition is also useful. It's given as a continuous IV infusion, and in fact it's light sensitive, so it goes around the hospital in a black bag, so you can always tell a patient who's on a nitroprusside drip. And you can see these cyanide moieties. It's actually 40% cyanide, so patients who get this drug can theoretically have cyanide toxicity. So those are the nitrates and nitroprusside, both nitric oxide donors. Now we're going to talk about kind of a mixed bag of vasodilator drugs, Nesiritide, Hydralazine, and Minoxidil. So Nesiritide is a mixed venous and arteriolar dilator. It's a recombinant B-Natriuretic peptide, and it's shown here on the right. Currently, its role is sort of undefined. It was very commonly used in the sort of mid-2000s for acute decompensated heart failure, but it's turned out in later clinical trials that there's no benefit. So if you just Google Nesiritide, you'll see a whole bunch of papers and controversy about it. Suffice it to say, it's a drug that can be considered in acute decompensated heart failure, but because it can drop blood pressure, it's really just used in patients with normotension or hypertension, but IV nitroglycerin or nitroprusside are probably better in patients with acute decompensated heart failure than Nesiritide. Hydralazine is an arteriolar vasodilator. The mechanism by which it somehow causes smooth muscle relaxation is unknown, but it does vasodilate. And the most common use that you'll probably see it for is in the hospital as an acute antihypertensive. So a patient with a blood pressure of 180/90, and the nurse calls you and says their blood pressure is 180/90. What do you want to do to lower the blood pressure? Oftentimes, hydralazine IV is administered. It's also a very useful sort of third or fourth line agent for chronic hypertension. So after you give people a drug like hydrochlorothiazide or an ACE inhibitor or a calcium channel blocker, but you're still having trouble controlling the blood pressure, it's a very useful drug, but its usefulness is limited by the fact that you have to dose it 3 times a day. And in some patients with heart failure with reduced ejection fraction, it can really be used in conjunction with nitrates. Nitrates, recall, are preload reducing. These are afterload reducing, so it's sort of preload and afterload reduction as chronic therapy for heart failure with reduced ejection fraction. So those are probably the 2 most common clinical uses for hydralazine. So minoxidil, you've probably seen it on TV as a therapeutic component of Rogaine. It's an arteriolar vasodilator. The mechanism isn't super clear, but it's thought to increase potassium channel activity in the smooth muscle, and what that leads to is membrane hyperpolarization and relaxation of the smooth muscle. And it's very useful as a third or fourth line agent for chronic hypertension. It's very effective, but again suffers from the limitation of having TID dosing and the very common side effect of hair growth and hirsutism. So in women, it's perhaps less commonly used. So that's sort of a mix of some of the vasodilator drugs, and we talked briefly about their indications. So now we'll talk about calcium channel blockers. Okay, so this is like kind of one of the classic tables in medicine that you should kind of memorize, because different calcium channel blockers, depending on their class, have different effects on vasodilation as arteriolar vasodilators and direct effects on the heart. So we think of them as dihydropyridines. The classic ones are amlodipine and nifedipine. They all end in pine. And these dihydropyridines are vasodilators strictly. And they don't really have any direct effects on the heart in terms of negative inotropy or AV nodal blockade. Verapamil and diltiazem, on the other hand, have direct effects on the heart, as well as vasodilation. And so I think one mnemonic is verapamil is the pumper's pill. That's how you know it is negative inotrope and AV nodal blockade. And I'll tell you my really dumb mnemonic. You would think that nifedipine should be in between, but it's not. So that's how I sort of remember through 2 steps that nifedipine is the opposite of verapamil. You would think that it's supposed to be in between diltiazem and verapamil. Okay, so that's calcium channel blockers, and that's a horrible mnemonic. The clinical uses for calcium channel blockers are listed here. So one is that it is really useful in angina because it's a vasodilator. That leads to decreased myocardial oxygen demand and increased blood supply. Rather, the vasodilation leads to increased blood supply, and the decreased myocardial oxygen demand is from the negative inotropy, although amlodipine can certainly be used for angina as well, even though it doesn't have a direct negative inotropic effect. It's very useful in coronary artery spasm, a condition like Prinzmetal's angina. These are very useful antihypertensives, and they're also used, recall, as supraventricular arrhythmias for rate control. They're the class 4 antiarrhythmic drugs. And so it's important to note it's only verapamil and diltiazem that have really antiarrhythmic activities. So again, despite these drugs being vasodilators, they don't have any benefit in heart failure. Okay, so we're sort of done recapping the mechanisms of the vasodilator drugs. We talked about venodilators, which decrease preload, arteriolar dilators, which decrease afterload, and sort of mixed drugs with mixed effects. I should mention that I skipped over talking about the alpha-adrenergic blockers and the alpha-2 center agonists because they were covered extensively in your renal ANS block, and I don't think I'm going to have anything intelligent to add to what Dr. Selinsky had to say. So let's talk about beta blockers, and I think there are two mechanisms that you should actually be aware of. And so here's the classic one, which explains its anti-anginal effects. So let's take a drug like epinephrine, or rather an endogenous hormone like epinephrine, and it's coming to the beta-adrenergic receptor on the cardiomyocyte. And it's beta-1 because most of the cardiomyocyte adrenergic receptors are beta-1. That leads to cyclic AMP, which leads to calcium, which leads to increased inotropy and chronotropy. The increased inotropy and chronotropy make increased oxygen consumption because the heart is beating faster and stronger. But the increased chronotropy also leads to a shorter diastolic period, and recall that myocardial perfusion is during diastole, so shorter diastole, you could potentially limit oxygen supply. So epinephrine or adrenergic signaling can lead to ischemia through increased oxygen consumption and decreased oxygen supply. So then a beta blocker like metoprolol blocks adrenergic stimulation and therefore can improve supply and demand of oxygen and improve ischemia. So this mechanism accounts for the anti-anginal and antihypertensive effects of beta blockers. But you might then wonder, okay, if this drug is a negative inotrope and chronotrope, then why is it useful in heart failure? How isn't it not just making the heart worse? And in fact, if you give too much beta blocker too fast in someone who's very sick with heart failure, you can make them worse, no doubt about it. But this is kind of what explains how a beta blocker can be helpful as chronic therapy in heart failure. So let's take a cardiomyocyte and let's put some more beta-adrenergic receptors on it. And here's the epinephrine. And let's say the patient is getting sicker and sicker with their heart failure. So they have more epinephrine because the body is trying to stimulate the heart to do more work. And so now there's a ton of epinephrine and norepinephrine and what have you. And now the heart is frankly failing, and it's in a toxic neurohormonal milieu. If you use that term on the wards, I think you'll impress some people. So this is a toxic neurohormonal milieu, and there is a built-in sort of negative feedback signaling mechanism in the adrenergic signaling cascade. And so what overstimulation of the beta-adrenergic receptor can lead to is stimulation of a protein called beta-adrenergic receptor kinase. That leads to phosphorylation of the beta-adrenergic receptor, which allows another protein called beta-arrestin to then bind to the beta-adrenergic receptor. What beta-arrestin does is pull the beta-adrenergic receptor off the cell surface membrane and in fact target it for degradation. So you pull a whole bunch of adrenergic receptors off the membrane, and what happens then is the cell is now desensitized to epinephrine. It's sort of protecting itself, but in the same process, it is perhaps limiting its ability to be stimulated and can lead to further sort of clinical failure potentially. So now the metoprolol comes along and blocks the beta-adrenergic signaling and interdicts this entire beta-adrenergic receptor kinase beta-arrestin pathway and restores sensitivity of the failing desensitized heart to adrenergic stimulation. So that's how potentially chronic therapy with beta blockers can help in heart failure. I think that concept can be tricky and it's important to understand. And again, this mechanism of restoring sensitization is thought to account for the efficacy of beta blockers in left ventricular systolic dysfunction. Okay, so antiarrhythmic drugs, I will go over them briefly and I would refer you to my screencasts too if you have kind of further questions, or definitely email me. And I thought what we'd do is just look quickly at the sodium channel blocker and potassium channel blocker salient effects. So recall that sodium channel blockers really are classified into 1A, 1B, and 1C drugs. And these drugs all vary on their the potency of their effect on the phase 0 slope, which is dictated by the sodium channel blockade activity. And some of these drugs also probably have potassium channel blocking activity, which accounts for its effect on the sort of phase 3 of the depolarization. So just remember that 1A drugs, but most importantly 1C drugs, are very high potency sodium channel blockers leading to a slower upslope of phase 0. And recall that 1A drugs have the most effect on phase 3 of the action potential, prolonging the action potential duration the most. And again, potassium channel blockers, the class 3 antiarrhythmics, prolong action potential duration because they interfere with potassium channels, which are responsible for repolarization of the cell membrane. Okay, so this is just to kind of see how much progress we've made in terms of recapping the mechanisms of cardiovascular drugs, and we've gotten to about the antiarrhythmic drugs, so not too bad. And we'll just talk briefly about diuretics. So here is here's a cutaway of a kidney, and here's the tubule. And there are 3 main sites of diuretic action that you should probably know about for this unit. So you should know about loop diuretics, for example, furosemide, that act at the thick ascending limb. Thiazide diuretics, which act in the distal convoluted tubule. And spironolactone, which blocks aldosterone, which stimulates transporters in the collecting duct. So clinically, we often use these drugs as antihypertensives, but also to control volume in patients with heart failure, whether it be heart failure with preserved ejection fraction or heart failure with reduced ejection fraction. And oftentimes we use these drugs in combination. Okay, so now let's talk about antithrombotic agents. And this can be really confusing, but I think the way to think about these agents is to think about the platelet inhibitors, aspirin, dipyridamole, the thienopyridine group of drugs, and the 2B3A inhibitors, the anticoagulants, vitamin K inhibitors, heparins, factor Xa inhibitors, direct thrombin inhibitors, and finally the thrombolytics, the 2 that you should probably at least recognize are TPA, or tissue plasminogen activator, and streptokinase. And shown here at the bottom is just the hemostatic cycle, and recall that it really starts kind of with platelet aggregation, but that's intimately linked with clot propagation, then finally clot termination and fibrinolysis. So first let's talk about the platelet inhibitors. And shown here is a platelet, and there are a lot of events that occur in a platelet to stimulate it, but the main job of a platelet is to recruit other platelets so that it can stick to them. And the main things that it sends out are thromboxane and ADP in order to stimulate platelet aggregation, and 2B3A, glycoprotein 2B3A, via its interaction with fibrinogen, is really critical in mediating platelets sticking to one another, because fibrinogen can stick to 2 platelets, so it can sort of cross-link the platelets. So shown here are a couple of receptors which are drug targets. So you should know about the 2B3A inhibitors, epsiximab, eptifibatide. These are IV drugs which block the 2B3A receptor, thereby preventing platelet aggregation. You should know about the thienopyridines. The most common class is or rather the most commonly used drug in this class is clopidogrel. These are oral medications largely, and they block the ADP-P2Y12 receptor. And what this receptor normally binds to is ADP and leads to platelet activation, but the thienopyridines interfere with this receptor. And the downstream signaling that's important in these ADP-P2Y12 receptors is a decrease in cyclic AMP, because these receptors are linked to cyclic AMP through G inhibitory signaling. So a drop in cyclic AMP leads to platelet activation. So by treating with the thienopyridine or clopidogrel, you can block platelet activation. You can see aspirin over here, which blocks thromboxane A2, thereby inhibiting thromboxane A2's effect to activate platelets. And the last drug here, which is sort of grayed out because it's not used that often in cardiology, but rather in neurology where it has an acute indication for stroke, is dipyridamole, which blocks cyclic AMP, thereby inhibiting platelet activation. Okay, those are the platelet inhibitors. Now let's talk about the anticoagulants. And here's the coagulation cascade. We'll briefly recap it, but I think it's really important to understand the coagulation cascade so that you can understand the anticoagulants. So the critical thing, the whole point of the coagulation cascade is to generate fibrin, because once you generate fibrin, you can start forming a clot. The other really big point is to generate thrombin, because thrombin has a lot of positive feedback at multiple levels in this pathway, not shown for clarity. So there's the intrinsic system and the extrinsic system, and you see a lot of different factors are activated in a cascade until you finally get thrombinogen cleavage to thrombin, and then finally fibrinogen cleavage to fibrin. So the first drug to look at is warfarin, and you should know that warfarin inhibits at factor 9, factor 10, factor 2, and factor 7. It also inhibits protein CNS and a couple other proteins. Recall that for the first couple of days you can actually have increased thrombogenesis because of differential half-lives among the factors that are inhibited. What we're going to do now is highlight factor 10A and factor 2A, because these factors are really important for understanding how heparin and some of the other drugs that are anticoagulants work. So we're going to draw here a little heparin. This is an unfractionated heparin, meaning it's sort of the natural heparin, and has molecular weights of up to 12 to 15 kilodaltons. It's actually a sugar. It's a glycosaminoglycan, about 30 or 40 residues maybe, and so it's depicted here. What we're going to do is highlight two specific regions of it. So one is what's called the pentasaccharide. So it's sort of 5 of the sugar moieties on one end, and something that I don't really know what to call, so we'll call it the tail. So these are important in understanding the different types of heparin and factor 10A inhibitors. So the way heparin works is it binds to antithrombin. And antithrombin can bind to thrombin, so that's why it's called antithrombin. So it can bind to thrombin through interaction with the full length of heparin. Antithrombin can also bind to factor 10A. And so unfractionated heparin has factor 2A inhibition or thrombin inhibition and factor 10A inhibition in pretty much a 1-to-1 ratio. Low molecular weight heparin is missing the tail, so that's drawn here. And so one of the names of the drugs in the class of low molecular weight heparins is enoxaparin, with a molecular weight of about 5 kilodaltons. And antithrombin again can bind to low molecular weight heparin, but because the tail is missing, this complex can really mostly only inhibit factor 10A, although there is some antithrombin activity too, with this semi-paradoxically named antithrombin. But low molecular weight heparin can really just interfere with factor 10A. And then the third class to know about are factor 10A inhibitors, one of them being fondaparinux. It's just the pentasaccharide strip, and it can bind to antithrombin, and pretty much all of this can do is inhibit factor 10A. So fondaparinux is an IV drug, And there are now recently available oral small molecules that we're not going to worry about too much, but in the next couple of years, their indications may expand, rivaroxaban being the most commonly used one. So those are unfractionated heparin, low molecular weight heparin, and factor Xa inhibitors. And broadly speaking, low molecular weight heparin and heparin are used in acute coronary syndrome, but we will recap those things later. So finally, you should know about direct thrombin inhibitors, bivalirudin, which was derived from a compound found in leeches, and they block thrombin directly. So these indications are just listed here. I think I would consider them beyond the pale because it's really complicated when you use these drugs. But just by way of example, bivalirudin can be used in acute coronary syndrome instead of heparin, or low molecular weight heparin as sort of a substitute drug. But how to incorporate these into clinical pathways is still sort of emerging. Okay, so we talked about platelet inhibitors, anticoagulants. Now we have to talk about the thrombolytics, or the clot busters. So we have here the coagulation cascade ending up in fibrin. And the way fibrin gets cleared, or a clot is resolved, is plasmin comes along and breaks down the fibrin. And plasmin is generated from plasminogen. And these thrombolytics work by stimulating plasmin formation. So TPA, or tissue plasminogen activator, does just what it says. Activates plasminogen to plasmin, which then can lyse the clot. So these are the clot busters. But since they are very potent medications, not only do they prevent new thrombus, but they actually break down old thrombus, they have very high bleeding risk. They can cause strokes, intracranial bleeding, and therefore they're really just restricted use in life-threatening emergencies. So the three emergencies that come to mind are in an ST elevation MI. It's a very good therapy for that, but what has superseded it is immediate percutaneous intervention. So when a cath lab is not available within, say, 180 minutes of patient presentation, it's often used in the right patients with ST elevation MI. Patients with a large ischemic stroke, provided that they don't have a head bleed, so ischemic stroke, and a massive pulmonary embolism, which leads to circulatory collapse. These are probably the three major indications for thrombolytics. Okay, so we talked about antithrombotic agents now, and now we will move on to lipid drug therapy. Okay, so this is a very complicated diagram of lipid transport, and I just wanted to use this to highlight a few things about lipid transport. So the first thing to know is that lipids come in through your digestion. Bile acids solubilize the fats, and the fats are taken up by the enterocytes, and through the lymphatics are sent into the circulation. The chylomicrons, which predominantly have a lot of triglycerides, then drop off triglycerides to the periphery because lipoprotein lipase releases the triglycerides to free fatty acids and allows those fatty acids to be taken up as nutrition. So now these chylomicrons are chylomicron remnants, and they can deposit residual triglycerides and cholesterol to the liver. So that's called the exogenous pathway, and that's shown here in green. So the other sort of pathway of transport of triglycerides and cholesterol is what's called the endogenous pathway. And so the endogenous pathway is when the cholesterol secretes in a VLDL particle, which has ApoB100, which is shown here in red, secretes triglycerides and cholesterol for purposes of nutrition in the body. So the VLDL, just like the chylomicron, comes along to the periphery and through the action of lipoprotein lipase releases free fatty acids for nutrition, and then gets turned into an intermediate density lipoprotein, and then finally low density lipoprotein, also containing ApoB100, shown here in red. Now, if LDL gets oxidized or modified in some way, shown down here next to the macrophage, it can be taken up by the macrophage and lead to foam cell formation, atherogenesis, etc. And finally, the last thing to kind of look at here is that HDL and reverse cholesterol transport may be an operative mechanism. So HDL may be able to sort of suck cholesterol out of the periphery and then deliver it to the liver. Okay, so that's just a brief overview of lipoprotein transport. And if you want more details, I'd encourage you to look at one of my lectures from Science and Medicine. I think it's lecture 125. So this is another one of those sort of classic diagrams in medicine that you should know about. It's a table where people will list different lipoproteins across one side and then list different drug classes down here and then show you which lipoprotein is modified with a particular drug. And I always found this really hard to sort of grasp. So I tried to make this a little bit better. And the way I tried to make it better was make in really big the arrows that are really the most important effect of that particular drug. So you can see here the HMG-CoA reductase inhibitors or statins. The most important thing about them clinically is that they can really lower LDL cholesterol. The bile acid sequestrants are really important because they can also lower LDL cholesterol. And for example, niacin is most important because of its HDL raising properties, and fibrates and fish oils or omega-3 unsaturated fatty acids are most important for their triglyceride raising properties. The other thing I did was try to code the magnitude of the effect by the number of arrows. So each arrow ballpark represents a 15% drop in that particular lipoprotein species at maximally therapeutic doses. So for example, with the highest potency statin, you can get to up to about a 60% drop in LDL cholesterol. So we'll go through the mechanisms of these different drugs here, and the most important mechanism to know is how a statin works. So the way a statin works is by interfering with HMG-CoA reductase, and we'll get to that in a second. So HMG-CoA reductase is the rate-limiting step of cholesterol biosynthesis in the liver. It's the committed step. Once you convert HMG-CoA to mevalonic acid, you're going to make cholesterol. So when the liver synthesizes cholesterol, what that does is it actually inhibits LDL receptor presence on the surface of the liver, because the liver doesn't need to try and suck up more cholesterol from the periphery. It's got plenty, it's making plenty on its own. Doesn't need LDL receptors out there in order to suck up more cholesterol. So when the liver is cholesterol replete, there are fewer LDL receptors on the surface of the liver, which means that LDL cholesterol, which is what we're measuring in circulation, is elevated. That is to say, the body is sort of has a lot of cholesterol flying around. The way a statin works is by inhibiting HMG-CoA reductase. When it inhibits HMG-CoA reductase, there's less mevalonic acid produced, and so there's less intrahepatic cholesterol. So that intrahepatic cholesterol inhibition of LDL receptors lifted, and actually the liver is now looking for cholesterol. So it sort of sucks it out of the body, and it puts a lot of LDL receptors out on its surface to try and take up LDL, and that's how statins work, because it increases the number of LDL receptors, which in turn lowers serum LDL cholesterol. Okay, so next I want to talk about how bile acid sequestrants work. And to know about how bile acid sequestrants work, you have to know about what's called the enterohepatic circulation. So basically what happens is bile acids are produced in the liver from cholesterol. So cholesterol is this precursor for bile acids. It goes in the gallbladder when you have a fatty meal. It goes into the gut lumen in order to solubilize the fats so that they can be taken up by the enterocytes. Now, distally in the gut, 95% of bile acids are actually taken back up by the portal vein and sent back to the cholesterol, rather to the liver, and are recirculated in that manner. So what that means is you're very efficient with your use of bile acids. So the way a bile acid binder or bile acid resin works is it binds up the bile acids in the gut and forces you to eliminate them. So what that means is then now your liver in order to have enough bile acids, is forced to synthesize more of them. And the way it synthesizes bile acids is by using up cholesterol. So when the liver now is using up the cholesterol, and the cholesterol depletion in the liver signals the liver to put up more LDL receptors, which then leads to more binding of LDL to the LDL receptors and lowering LDL cholesterol levels. So bile acid sequestrants after statins are a pretty good choice as a second-line lipid-lowering agent. Ezetimibe works by interfering with absorption of cholesterol from the gut. So ezetimibe binds to what's called the MPC1L1 receptor, Niemann-Pick something L1 receptor, and that's what's responsible for cholesterol uptake in the gut. So by blocking this, dietary uptake of cholesterol is inhibited. Now, clinical trials have been sort of disappointing and at cross purposes, so its clinical role currently is unclear, but maybe it's useful as a second or third line LDL lowering drug. So now let's talk about the mechanisms of niacin. And there are really three mechanisms by which niacin works. And it's not 100% clear to me that these are all ironclad mechanisms, but at least this is what we think we know. So one thing that niacin does is that it decreases liver triglyceride synthesis. And triglycerides are a big part of the endogenous pathway of lipoprotein metabolism. So triglycerides are really important for making VLDL, which, as you'll recall, eventually gets processed to LDL. So when you inhibit liver triglyceride synthesis, what you're doing is you're sort of slowing down the production of VLDL. It takes longer for your liver to package up the VLDL. The VLDL that's trying to be made is waiting around for triglycerides in order that it can get going. And while that VLDL that's sort of being developed is waiting around, the ApoB100 is in the liver. And there's this chronic sort of degradation of ApoB100 that's the key apoprotein on VLDL and eventually LDL. So the ApoB100 is just sort of sitting around in the liver, and eventually it just gets degraded. So by blocking liver triglyceride synthesis, you slow down this pathway, and eventually you degrade ApoB100, meaning that you get less VLDL production and less LDL production. Now, VLDL is one of the major components of VLDL is triglycerides. So by having less VLDL production, you have lower triglycerides. And of course, one of the major components of LDL is LDL cholesterol. So by blocking the VLDL, you have less LDL and you have lower LDL cholesterol. So that's sort of one big pathway, blocking triglyceride synthesis and leading to degradation of ApoB100. A second big pathway is that niacin blocks mobilization of triglycerides from the adipose tissue. So the adipose tissue are the fat depots in the body, and niacin blocks mobilization of triglycerides from them, which also leads to lowering of triglycerides. The third major effect of niacin is it affects degradation of ApoA1. And ApoA1 is the main lipoprotein on HDL. So if you have less ApoA1, you have less HDL cholesterol. So by blocking degradation of ApoA1, it allows more ApoA1 to form HDL, and so you actually have higher HDL cholesterol with niacin. So niacin leads to lower triglycerides, lower LDL cholesterol, and higher HDL cholesterol. Now we'll talk about the mechanisms of PPAR alpha agonists, or the fibrates. And fibrates also have pretty similar mechanisms of activity through different receptors. So one thing that gemfibrozil, shown here as the example, does is it blocks liver VLDL secretion. And so by blocking liver VLDL secretion, it can reduce triglyceride levels. Let's talk now about its effects on HDL cholesterol, and then we'll come back to its effect on lipoprotein lipase activity. So gemfibrozil stimulates synthesis of ApoA1, which we talked about with niacin. It also stimulates synthesis of ApoA2, and these are the two main lipoproteins on HDL. So basically, ApoA1 is the most abundant form, and ApoA2 is probably the second most abundant form. And these apoproteins, when synthesized more, mean that there's more apoprotein available to form HDL, and so there's higher HDL cholesterol. So decreased triglyceride, higher HDL cholesterol. So recall that lipoprotein lipase is responsible for changing triglyceride into free fatty acids so that it can be delivered to the peripheral cells as a form of nutrition. So in that manner, because lipoprotein lipase is chewing up the triglycerides, is decreasing blood triglyceride levels, whether those triglycerides be coming from VLDL or from chylomicrons. ApoC3 is a very complicated to understand lipoprotein, but suffice it to say that ApoC3 is thought to inhibit lipoprotein lipase activity. And also suffice it to say that it's thought that gemfibrozil inhibits ApoC3 expression. So there are three negatives here. There's an inhibition by gemfibrozil of ApoC3, which deinhibits lipoprotein lipase, which then allows lipoprotein lipase to decrease triglycerides. So you can see that gemfibrozil administration will lower triglyceride levels. So those are the mechanisms by which fibrates may work. And the mechanism for omega-3 fatty acids is by also decreasing liver VLDL and ApoB synthesis, thereby lowering triglycerides. So omega-3 fatty acids are most useful clinically for patients with very high triglycerides and for lowering that. They're also used because there may be separate uses in the case of myocardial infarction, but that's sort of a separate issue than its lipid effects, we think. So those are the lipid-lowering therapy drugs. The mechanisms, the most important mechanism to know is statins and probably bile acid sequestrants. The other mechanisms can be complicated, but they also lead to their various effects on lipid fractions. So we're almost done. The last mechanism to talk about is ranolazine, which recall is sort of another anti-anginal drug that can be used. It can be used in conjunction with beta blockers, calcium channel blockers, and nitrates, and it doesn't fit neatly into any of the categories. So to understand the putative mechanism of ranolazine, you have to remember the action potential. And recall that sodium influx usually occurs during phase 0 of the action potential. In ischemic myocardium, it turns out that there's also potentially a late sodium current. So there's continued activation of sodium, and the reasons for this aren't entirely clear. But it's thought that this late sodium current can lead to an increase in intracellular sodium. And so recall that there's the sodium-calcium exchanger, which links sodium levels and calcium levels. And if the intracellular sodium level is higher, there can be more extrusion of sodium through this exchanger, forcing more calcium into the cell, forcing contractility in this ischemic cardiomyocyte, which is already not getting enough blood, forcing increased oxygen demand, leading to ischemia. So bottom line, these late sodium currents can exacerbate ischemia in ischemic cardiomyocytes, and it's important to know that this late sodium current is found more in ischemic cardiomyocytes than in healthy cardiomyocytes. So it's proposed that ranolazine blocks this late sodium current. So that blockage of the late sodium current means that you don't get this increased calcium and increased contractility intracellularly, thereby dropping oxygen demand and reducing ischemia. And again, clinically, it's used as second or third line anti-ischemic along with beta blockers, nitrates, and calcium channel blockers. So that's sort of a recap of a lot of mechanisms of drugs. And the next screencast, what we'll do is actually pull these indications together and figure out some clinical uses for them. Thank you.